Hello, my name is Jenny. You may call me Jen, and I'm going to be recording this online residency program that I'm currently working on. It's actually for reference so that I have a record on what I have done and how much time I have spent for one particular course. For this one, it's called just a moment. Can you see this? Yeah. Okay. All right. So for this one, it's particularly called Navigating Clinical Alarm Hazards and Strategizing Solutions. It says it's past due. That's why I'm kind of rushing this. It's already September 18 now, and I have to rush. Okay, let's begin. Oh, okay. So I have to finish this pre-test first. I need to score 0 out of 10. And I have 1 attempt remaining to pass this test. Okay. Which clinical alarm hazards has been shown to contribute to adverse events in hospitals nationwide? Which clinical alarm hazards has been shown to contribute to adverse events? Unnecessary. All of the above. Clinical staff can play a significant role in reducing alarm fatigue by educational offerings. Participating in educational offerings that speak specifically to alarm fatigue. Becoming their unit's champion and offering to participate in unit level reviews of the problem. Relying on special administration to carry out a full-scale alarm management program, both A and B, I think. Question 3 of 10. Which of the following factors was not identified by the Joint Commission as contributing to alarm-related sentinel events? A, insufficient monitored beds in intensive care and telemetry units, improperly set alarms, failure to customize alarms to individual patients and patient populations, alarm fatigue was not identified. Of course, alarm fatigue was identified. Failure to customize alarms. Improperly set alarms, of course. Insufficient monitored beds in ICU. Of course, this one. Which statement is true regarding the heightened level of incoming sensory information seen in hospital environments today? Which statement is true? Sensory information. The ability of clinical staff to recognize and respond to critical alarms appropriately is not affected. Of course, it's affected. Healthcare team members are becoming desensitized to noticing and responding to alarms. Of course not. The level of false or non-actionable alarms is very low. Patients and families are positively affected by alarm sounds. Of course. True. Which of the following actions has a potential to reduce false or non-actionable alarms? Which of the following actions has the potential to reduce false or non-actionable alarms? Cleansing the cardiac electrode. So, ensuring alarms are customized and patient within 1 hour of shimming care. Placing electrodes over bony Shake muscles. Troubleshooting false alarms. Types of alarms. Troubleshooting false alarms. Unable to analyze. Cleansing soap and water. Do we cleanse it with salt, soap and water? No. Ensuring alarms are customized. Yes. Which of the following is true of actionable alarms? Actionable alarms require no immediate. Of course not. Actionable alarms are due to transmission of misinformation, such as artifact caused by patient movement. No action represent clinical event requiring tolerance and touch. Some type of therapeutic response to avoid. Yes, actionable alarms are caused by no. To ensure the correct ECG pattern is obtained and to avoid misdiagnosis of an incorrect cardiac rhythm, clinician must make sure the correct lead wire is attached to the correct electrode. Of course, measure electrode, verify ECG signal is stable, of good quality. To avoid misdiagnosis, document change in electrode position or lead selection. Okay, ensure no changes are made to factors that limit during the period the patient's monitored. I don't know. I don't know. Ensure no changes are made to factory set limits. All right. Question 8. Negative effects of noise on patients include which of the following? Lowered pulse rate, severe and delayed without abdominal cramps, decreased moving. According to the AAC and ECG electrodes should be changed. Wow. Daily. Should be changed daily, those electrodes. Not sure. The 2013 AACN practice alert on alarm management included which of the following recommended actions to reduce alarm fatigue? Provide proper skin preparation for ECG electrodes, change ECG electrodes daily, monitor only those patients for monitoring, monitor only those patients. Provide initial and ongoing mobile devices with alarms. Why only those in clinical indications for monitoring? What if they don't show clinical indications, but they can provide mission? I don't know. Of course. 50%. Okay, exit test. All right, online course. It says here, wait. It says here, the estimated time is 1 hour and 27 minutes. Okay, let's see if I need 1 hour and 27 minutes. I'm tired already. I've been working all day. But
welcome to this continuing education program on navigating clinical alarm hazards and strategizing solutions.
wow, that's nice. To successfully complete this course, you will reach knowledge check. Wow, love it. Wow, the references are here. Okay, just took a screenshot of all the questions. And Table of contents. Wow, that's a lot. Course completion. Okay, let's see. This course is divided into 3 sections. Clinical alarm hazards, defining the issue, national initiatives regarding clinical alarm hazards, strategies for reducing clinical alarm hazards at the bedside. To successfully complete this course, review each slide, complete each knowledge check. If you exit the course before completing, you may start from where you left off or from the beginning. Okay, let's begin.
Clinical alarms are designed to notify clinicians of immediate or potential harm to patients. Although these alarms provide critical alerts that can save lives, they can also negatively impact the healthcare environment. As a result of participating in this continuing education activity, the learner should be able to A. Discuss the scope and significance of clinical alarm hazards and their effect on everyday practice. B. Explain national initiatives regarding clinical alarm hazards and their integration into the workplace. And C. Apply proven clinical strategies to practice in order to reduce clinical alarm hazards and improve patient safety. In today's clinical environment, healthcare face many challenges in delivering safe, high-quality patient care. Although our technological advances provide targeted treatment to some of the most complex healthcare issues, they also add a level of risk. Clinical alarms, especially those related to physiologic monitoring of the patient, can provide protection and reduce risks for patients. While they are designed to alert the clinician to the subtlest change in the patient's condition, their sensitivity and/or improper use creates a high volume of non-actionable alarms. Add that to an already noisy clinical environment, and the importance of recognizing and proactively minimizing clinical alarm hazards becomes more obvious. In order to assist those providing direct patient care in furthering their education. Welcome to this continuing education program on navigating clinical alarm hazards and strategizing solutions. Clinical alarms are designed to notify clinicians of immediate or potential harm to patients. Although these alarms provide critical alerts that can save lives, they can also negatively impact the healthcare environment. As a result of participating in this continuing education activity, the learner should be able to A. Discuss the scope and significance of clinical alarm hazards and their effect on everyday practice. B. Explain national initiatives regarding clinical alarm hazards and their integration into the workplace. And C. Apply proven clinical strategies to practice in order to reduce clinical alarm hazards and improve patient safety. In today's clinical environment, healthcare workers face many challenges in delivering safe, high-quality patient care. Although our technological advances provide targeted treatment to some of the most complex healthcare issues, they also add a level of risk. Clinical alarms, especially those related to physiologic monitoring of the patient, can provide protection and reduce risks for patients. While they are designed to alert the clinician to the subtlest change in the patient's condition, their sensitivity and/or improper use creates a high volume of non-actionable alarms. Add that to an already noisy clinical environment, and the importance of recognizing and proactively minimizing clinical alarm hazards becomes more obvious. In order to assist those providing direct patient care in furthering their education on this issue and provide training on how they can become part of the solution, this continuing education activity will begin by clarifying the scope and significance of clinical alarm hazards and their effect on everyday practice. We will start with an overview of clinical alarm hazards. In 2006, the American College of Clinical Engineering, ACCE, Healthcare Technology Foundation, HTF, published a white paper titled Impact of Clinical Alarms on Patient Safety. It succinctly states, for a clinical alarm to be effective, it must be triggered by a problem that adversely affects the patient, and personnel must identify the source and meaning of the alarm and correct the problem before an adverse patient event. In today's hospital environment, clinical staff are inundated with alarms related to ECG monitoring, continuous pulse oximetry monitoring, smart alarms, bed alarms, IV pump alarms, and more. Due to the heightened level of incoming sensory information, healthcare team members can become desensitized to noticing and responding to the alarms.
Okay, just a moment. I need to do something. I need to go to system preferences. Just a moment. System preferences. And then settings, system settings. Send. Because wait, system preferences and then sound, play sound effects, play sound and start that, play user interface sound effects. Play, oh, okay. There you go. All right, now I can share it again. Just a minute. Okay, let's see. All right.
Physiologic alarms are a common source of alarm hazards. In particular, physiologic alarms produce a high percentage of false or non-actionable alarms, resulting in little or no change in patient management. Consider a few examples from the 2011 AAMI Clinical Alarms Summit. Stanford University Medical Center reported an average number of 883 alarm signals per unit per day, and found that 43% of the alarms required no action. Children's National Medical Center reported one unit had an auditory alarm signal every 92 seconds. In the neonatal unit, one auditory alarm was experienced every 66 seconds. Yet 85 to 95% of these alarms were considered non-critical false positives. Johns Hopkins Hospital was able to reduce their average of 350 alarm conditions per patient per day by 43% by one simple action, changing ECG electrodes daily.
Oh, okay.
In 2006, the American College of Clinical Engineering, ACCE, Healthcare Technology Foundation, HTF, published a white paper titled Impact of Clinical Alarms on Patient Safety. It succinctly states, for a clinical alarm to be effective, it must be triggered by a problem that adversely affects the patient, and personnel must identify the source and meaning of the alarm and correct the problem before an adverse patient event. In today's hospital environment, clinical staff are inundated with alarms related to ECG monitoring, continuous pulse oximetry monitoring, smart alarms, bed alarms, IV pump alarms, and more. Due to the heightened level of incoming sensory information, healthcare team members can become desensitized to noticing and responding to the alarms. For clarity, let's briefly review the different types of alarms encountered in the clinical environment, two of which have already been mentioned. Actionable alarms. Alarms that require a timely response and potentially some type of therapeutic intervention to avoid an adverse effect. False alarms. Alarms due to the transmission of misinformation, such as artifacts related to patient movement, or incorrect lead placement. Non-actionable alarms, true alarms that do not require therapeutic intervention. Nuisance alarms, high occurrence of non-actionable alarms that become an annoyance to staff and distract from patient care. Reduced sensitivity to these various alarms, coupled with a rising tide of alarms in general, has produced a potentially dangerous clinical environment. In some cases, the results have been devastating. From January 2005 through June 2010, 566 alarm-related deaths were reported to the Food and Drug Administration. From January 2009 through June 2012, 80 deaths were reported to the Joint Commission Sentinel Event database. In addition, clinical alarm hazards have reached an all-time high in public awareness. In 2010, an 89-year-old man's cardiac monitor alarm sounded for over 20 minutes. Within those 20 minutes, his heart rate slowed and stopped. The investigation showed the alarm was turned off. It also revealed the volume settings could be easily and inadvertently modified by staff. This case settled for $850,000. In 2013, a 17-year-old female underwent a tonsillectomy without complications. Her surgery was conducted in an ambulatory care center. Post-operatively, she received fentanyl for pain. During a 25-minute span in which she went unmonitored, she suffered a respiratory arrest and later died. In this case, alarms monitoring both her cardiac and respiratory function had been muted. Cases like these have spurred the healthcare community to action. As we will discuss in just a few minutes, many national organizations are assisting the effort by providing best practice guidance. Addressing clinical alarm hazards requires a comprehensive alarm management program that includes stakeholders from across each healthcare organization. The increased noise within clinical units caused by a multitude of alarms has resulted in at least one of two responses. Staff are no longer able to discern which alarm is truly urgent, and/or staff inappropriately silence persistent alarms by turning down the volume, turning them off, or adjusting them outside the appropriate limits. Improper alarm settings and inappropriate alarm management are just two factors that contribute to these adverse events. It should be noted that multiple factors are involved, including unnecessary monitoring of patients, alarm fatigue, and improper skin care and/or electrode placement, replacement. In 2010, the medical records of 1,816 patients in 17 hospitals were reviewed. Review criteria required that arrhythmia, ischemia, or QT interval monitoring had been performed. The study revealed nearly 85% of arrhythmia-monitored patients, 26% of ischemia-monitored patients, and 18% of QT interval-monitored patients had no clear medical indication for such monitoring. Alarm fatigue has been described as desensitization to an alarm stimulus that results from sensory overload. Simply put, alarm fatigue occurs when the number and frequency of alarms becomes overwhelming. This phenomenon has been observed in two other industries, aviation and automotive. It can cause a delayed or even missed response to alarm conditions and potentially result in patient harm or death. Finally, minimizing false alarms through proper skin prep and electrode placement and replacement are actions that can significantly reduce the number of alarms. In one study, the number of alarms decreased an average of 46% per bed per day by simply changing electrodes daily. Providing excellent care in this area may substantially reduce the number of false alarms. Since physiologic monitoring remains at the center of clinical alarm hazards, we will explore this topic a little more deeply. Physiologic monitors have become a permanent fixture not only in the intensive care units of our hospitals, but also on many of the regular units. This type of technology has flourished, but it also has significantly raised the number of alarms within the clinical environment. According to the AACN Practice Alert on Alarm Management, the number of alarms per patient per day has increased exponentially, from an average of 6 alarms per patient in 1983 to around 40 alarms per patient in 2011. Yet studies have shown that after being introduced to more than 6 different alarms, a person's ability to differentiate them decreases. Furthermore, because these alarms are critical and rely on a quick response to avoid a negative outcome, clinicians must be educated on the life cycle of an alarm in order to assist with troubleshooting in this area. Let's examine the normal alarm process. This process begins when a condition crosses a preset threshold, triggering the alarm. It continues until there is resolution of the alarm. As an example, consider a patient who develops an arrhythmia that crosses the threshold of the set parameters. The patient who is in sinus rhythm with a heart rate of 80 converts to atrial fibrillation with a rapid ventricular response and a heart rate of 170. In this case, 2 thresholds may have been crossed, the rhythm regularity and the heart rate. Once the patient's values cross the threshold, an alarm sounds. The alarm sound is communicated to the appropriate clinician through direct notification, that is, the clinician sees or hears the monitor alarm, or through a middleware device, for example, pager, phone, or from a monitor technician. The sound of the alarm should indicate the level of urgency of the alarm condition, allowing the clinician to know how quickly to respond. The clinician intervenes, the patient condition is addressed, and the alarm is resolved. Thoroughly analyzing each step in the process can help both the clinician and the facility identify potential issues or risks. A properly set monitoring device should only alarm with a relevant change in a patient's condition, or if a problem with the device itself arises. Each clinician is responsible to set their patient's alarm parameters to ensure they are notified of an actionable alarm, an alarm that requires clinical intervention. Consider the barriers in your unit or facility that can keep these steps from running smoothly. Physiologic monitor alarms should contain sufficient information for clinicians to immediately identify the criticality of the alarm, allowing them to respond in a timely fashion. As such, medical device alarms, such as physiologic monitor alarms, are designed to notify staff based upon an alarm hierarchy. The greater the risk to the patient if the alarm is not responded to in a timely fashion, the more noticeable the alarm should be. Equally important, the alarm should be audible or visible in the clinical environment with normal unit activity. Research has shown, however, that staff who are able to hear or see alarms will respond based on perceived criticality and reliability. If staff believe an alarm is actionable 90% of the time, they will respond 90% of the time. If they perceive it to be actionable 10% of the time, they will respond 10% of the time. In addition to communicating a change in a patient's physiologic status, an alarm can inform a clinician that there is a potential or actual device failure. The potential malfunction could be something as simple as a low battery alarm for a portable monitor, or as serious as a complete shutdown of the central station. Thus, patient safety can be compromised several ways. Insufficient information communicated about the alarm condition by the device, failure of staff to hear or see an alarm, and failure of staff to respond appropriately to an alarm. It is essential that staff know and understand the alarm hierarchy to be able to respond appropriately to each alarm type. Inability to do so may result in a devastating outcome for the patient. In Section 1, the learner was provided an overview of clinical alarm hazards, a review of the scope and significance of the issue, details on why physiologic monitor alarms play such a key role in this issue. Please complete the following scenario and knowledge check as a way to review the information presented in Section 1. The next section will present information on the national initiatives enacted in response to clinical alarm hazards, as well as a detailed look at cardiac monitoring. Luke Brown is a 62-year-old patient with interstitial pulmonary fibrosis who is well known to your unit. He has had multiple admissions over the past 3 months for a resistant pneumonia. He is admitted to your unit from the physician's office for another round of IV antibiotics. His vital signs are BP 112/62, heart rate 108, respiration rate 26, temperature 100.8. Luke is on continuous pulse oximetry and high-flow oxygen. Because he has been a patient on your floor in the past, you know that his normal pulse ox is 85%. The current default alarm for his pulse ox is 90%. His pulse ox alarm is going off incessantly. You are the charge nurse on the floor. Luke's assigned nurse just finished orientation. What are your options? Take a couple of minutes to review this scenario. In this case, there are a few options. As the charge nurse, use this as a teachable moment. With Luke's nurse, assess the patient to ensure the pulse ox values are accurate, review the alarm history and the patient's history, and ask the question, when do you want to be called to the monitor? In other words, what pulse ox level would require clinical intervention? Second, since his normal pulse ox is 85%, the alarm can be set lower at around 80 to 82%. Lastly, be sure to follow your unit's and/or facility's policies for adjusting normal unit default settings. Click the letter below that best completes the statement. While clinical alarms are designed to alert the clinician to the subtlest change in the patient's condition, their sensitivity creates a high volume of A. Actionable alarms, B. Non-actionable alarms, C. Silent alarms, D. Critical alarms. Clinical alarms, especially those related to physiologic monitoring of the patient, can provide protection and produce risks for patients. While they are designed to alert the clinician to the subtlest change in the patient's condition, their sensitivity and/or improper use creates a high volume of non-actionable alarms. We will now review the national initiatives surrounding clinical alarm hazards. In doing so, the learner is provided a backdrop of past actions taken and a view of current and future goals to improve patient safety in this area. Since the intervention of physiologic monitoring, clinical alarms have existed. Over the last several decades, both the types of physiologic monitors available and the clinical alarms built for them have advanced technologically. According to the research of Sendelbach and Funk, the first clinical alarm-related sentinel event was reported in 1974. Since that time, research in this area has continued. However, a greater level of awareness was not fully realized until around the early 2000s. By 2007, enough evidence had been gathered that compelled ECRI, formerly Emergency Care Research Institute, to begin listing clinical alarm hazards on its annual Top 10 Health Technology Hazards Report. In 2011, ECRI, the Food and Drug Administration, FDA, the Joint Commission, the American College of Clinical Engineering, ACCE, and the Association for the Advancement of Medical Instrumentation, AAMI, came together at a summit to discuss the increasing concern with clinical alarm safety. The AAMI Joint Summit identified these 7 priorities related to alarm safety. 1. Expand stakeholders' understanding of the environments where alarms are used. 2. Improve alarm system management. 3. Explore methods of alarm integration. 4. Examine and reconcile challenges in care areas where alarms are used. 5. Strengthen medical equipment standards. 6. Clarify regulatory requirements. 7. Share best practices and lessons learned. AAMI, following the 2011 summit, published Recommendations for Alarm Signal Standardization and More Innovation. It featured a 5-year alarm system implementation plan undertaken by Christiana Care Health System. In the report, the AAMI was able to articulate specific recommendations that could be duplicated by other organizations looking to improve clinical alarm safety, such as assessing the current alarm systems in place, identifying true alarm conditions, and use of a task force to promote change. Since then, AAMI has highlighted other successful alarm initiatives, like Johns Hopkins Hospital's award-winning Alarms Initiative, in its Safety Innovation Series white papers, which are available at the AAMI website. Today, there are many key players in the advancement of alarm safety who are helping to shape national policy. In 2014, under the AAMI, the National Coalition for Alarm Management Safety was formed. This group is comprised of hospitals leading the effort to address alarm safety challenges, clinicians and professional societies such as ECRI, the FDA, the Joint Commission, and representatives from the medical device industry. The coalition's goals focus on improved alarm management and reduction of alarm fatigue, as well as providing resources through seminars, publications, presentations, and tools. What does all of this mean for the individual hospital? Let's take a closer look at recent actions by the Joint Commission, formerly JCO. In 2013, the Joint Commission released a Sentinel Event Alert specific to hospital alarm safety. The alert identified numerous factors as contributing to alarm-related sentinel events and cited alarm fatigue as the most common cause. Factors listed were alarm fatigue, failure to customize alarms to individual patients or patient populations, improperly set alarms, disabled alarm signals, inadequate staffing, inadequate staff training on equipment, inadequate or absent alarm systems, equipment malfunctions or failures, lack of integration of alarm conditions and settings with other medical devices, inaudible alarms. The Joint Commission's recommendations in the Sentinel Event Alert included secure leadership support, assess current alarms and their settings, establish guidelines for alarm parameters, create guidelines that tailor alarm settings, limits, on a patient-to-patient basis, regular alarm checks for properly functioning equipment, and staff education. The following year, the Joint Commission published a National Patient Safety Guideline, NPSG 06.01.01, which focused on reducing nuisance alarms and improving the effective use of monitoring technology. Under this NPSG, hospitals were required to prioritize alarm safety by July 2014 and to identify the most critical alarms within the organization by the end of 2014. Since 2016, hospitals are required to have specific policies and procedures relative to critical alarms, such as clinically appropriate settings for alarm signals, when alarm signals can be disabled, when alarm parameters can be changed, who has the authority to set the alarm parameters, who has the authority to set parameters off, monitoring and responding to alarm signals, checking individual alarm signals for accurate settings, proper operations, and detectability. Numerous organizations have developed resources and tools to assist hospitals in meeting the Joint Commission requirements. ECRI, for example, who named alarm hazards the #1 technology issue in 2012 and 2013 in its Top 10 Technology Hazards report, produced the Alarm Safety Handbook, Strategies, Tools, and Guidance reference tool in 2014. Through the work of these 3 agencies, as well as others, some key standards and guidelines have been developed to help institutions improve clinical alarm safety. Areas of current focus include generating organizational support, analyzing current alarms systems, aggregating and mining data collected, seeking out and combating instances of alarm fatigue, examining alarm standardization strategies, ensuring alarm settings are actionable, considering environmental conditions, providing regular staff education, assessing overall patient satisfaction. So what does the future of clinical alarm management hold? We will look briefly at some proposed future goals. Although progress has been made in the quest to improve patient safety in the area of clinical alarm hazards, there is still much to be done. All parties involved, from professionals to institutions to manufacturers, have a part to play. 4 key areas identified by Sendelbach and Funk that require further investigation are false alarms, non-actionable alarms, appropriateness of monitoring, processes of care. Before leaving the topic of national initiatives, we will review how some national organizations are specifically addressing cardiac monitoring alarm issues. Three specific organizations involved with improving cardiac monitoring techniques and avoiding associated clinical alarm hazards are the American Heart Association, AHA, American Association of Critical Care Nurses, AACN, American College of Cardiology, ACC. In 2004, the AHA brought together distinguished members of the cardiac community to develop a consensus statement regarding best practices in cardiac monitoring. This document is still considered and referred to when discussing cardiac monitoring needs and patient safety. Since at the time of its release, current technology for monitoring ST segment changes or computerized QT interval assessment was either underutilized or non-existent, the committee sought to provide guidance based on current expert opinion and any research known to date. As stated in the article, this consensus document represents the first attempt in the literature to encompass all areas of hospital cardiac monitoring, including arrhythmia, ischemia, and QT interval monitoring in both children and adults. Its recommendations gave specific guidance on when cardiac monitoring is appropriate in specific cardiac patient populations. It introduced a 3-tier classification system for determining when cardiac patients required cardiac monitoring. It specifically addressed ST segment ischemia and QT interval monitoring concerns. In addition, it reviewed current cardiac monitoring systems as well as electrode placement. Lastly, guidance was given on staffing, training, and ECG monitoring quality improvement needs. In 2013, the AACN released an AACN Practice Alert specific to alarm management. Its position paper on alarm management targeted reducing alarm fatigue and improving patient safety. As with other position papers, its guidance is supported by evidence-based documents. Guidance includes topics such as provide proper skin preparation for ECG electrodes, change ECG electrodes daily, customize alarm parameters and levels on ECG monitors, customize delay and threshold settings on oxygen saturation via pulse oximetry, SpO2 monitors, provide initial and ongoing education about devices with alarms, establish interprofessional teams to address issues such as the development of policies and procedures, monitor only those patients with clinical indications for monitoring. Again, the ACC is responsible for publishing the first classification system regarding the appropriateness of cardiac monitoring in specific patient populations. Although it was published in the early 1990s, the guidance document is still used today to evaluate cardiac monitoring needs. In their statements on cardiac monitoring, the ACC made a significant connection between the need for human interaction between the provider and patient when reviewing and assessing cardiac monitor data and when treating the patient. By providing this guidance document, the ACC gave a foundation to current cardiac monitoring guidelines. Today, all 3 organizations, that is AHA, AACN, and ACC, continue to be actively involved in monitoring the issue of clinical alarm hazards. As new research comes to the forefront, learners should look for updated guidelines from these organizations and others. In Section 2, the learner was provided an overview of national initiatives surrounding clinical alarm hazards from AAMI, the Joint Commission, and ECRI, a review of the current regulatory standards and guideline recommendations, as well as some future research needs. Details on how the AHA, AACN, and ACC have played a role in cardiac alarm hazard initiatives. Please complete the following scenario and knowledge check as a way to review the information presented in Section 2. In the next section, we will review practice strategies that, when performed by the clinician at the bedside, reduce clinical alarm hazards. Barbara White is a 45-year-old female patient admitted to your GYN oncology unit for pain management. She was recently diagnosed with history of stage 4 ovarian cancer. She has a history of asthma, diabetes, and atrial fibrillation. Her atrial fibrillation is well controlled on metoprolol, 50 milligrams twice a day. On admission, her blood pressure is 118/66, heart rate 72, respiration rate 14, temperature 98.2. You notice in the initial orders that the provider ordered telemetry. During your admission assessment, the patient tells you her heart rate has been well controlled on her current therapy for 2 years. Let's take a couple of minutes to think about this scenario. From the actions listed on the next slide, select the best answer choice or choices. Click the letter below that best completes the statement. At this time, what is the best action to take? A. Place patient on telemetry, adjusting limits per unit protocol. B. Collaborate with the provider to review the evidence-based indication for cardiac monitoring. C. Disable the irregular heart rate alarm setting. D. Document the patient's normal heart rhythm on the admission rhythm strip and nurse's notes. Barbara White is a 45-year-old female patient admitted to your GYN oncology unit for pain management. She was recently diagnosed with history of stage 4 ovarian cancer. She has a history of asthma, diabetes, and atrial fibrillation. Her atrial fibrillation is well controlled on metoprolol, 50 milligrams twice a day. On admission, her blood pressure is 118/66, heart rate 72, respiration rate 14, temperature 98.2. You notice in the initial orders that the provider ordered telemetry. During your admission assessment, the patient tells you her heart rate has been well controlled on her current therapy for 2 years. Let's take a couple of minutes to think about this scenario. Click the letter below that best completes the statement. At this time, what is the best action to take? A. Place patient on telemetry, adjusting limits per unit protocol. B. Adjusting the irregular or atrial fibrillation alarm and documenting the patient's current rhythm are appropriate actions if the patient is going to be monitored. However, since you have assessed your patient and read through her history, your best course of action is having a discussion with the provider about the need for telemetry monitoring in this patient's case. What would be the key points that you should click the letter below that best adjusting the irregular or atrial fibrillation alarm and documenting the patient's current rhythm are appropriate actions if the patient is going to be monitored. However, since you have assessed your patient and read through her history, your best course of action is having a discussion with the provider about the need for telemetry monitoring in this patient's case. Select all that apply. Hospitals are now required by the Joint Commission to develop policies and procedures surrounding clinical alarms, such as A. Allowing clinicians to silence annoying alarms. B. Who has the authority to change the alarm parameters? C. Clinically appropriate settings for alarm signals. D. Requiring that less than 10% of patients are monitored. Allowing clinicians to silence annoying alarms is incorrect, since silencing annoying alarms does not address the underlying cause and may prevent staff from being alerted to an actionable alarm. Requiring that less than 10% of patients are monitored is incorrect, as the Joint Commission does not specify a percentage of patients who should be monitored, but instead requires policies and procedures guiding the safe management of alarms on patients being monitored. Clinical alarm management begins at the bedside. Therefore, this section provides detailed guidelines on how you, the clinician, can help to reduce clinical alarm hazards and improve patient safety. Let's start the discussion with strategies to reduce alarm fatigue. Clinical staff play a large role in making substantial changes to clinical practice. In order to reduce the occurrence of alarm fatigue, staff should take an active role in educating themselves and their peers on how this desensitization can occur and how alarm fatigue is closely associated with alarm management. To that end, as a staff member, you can help by participating in educational offerings that speak specifically to alarm fatigue and/or alarm management, attending in-services on your unit's current monitoring systems and alarms, as well as new equipment being introduced to the unit. If it has been a while since any unit-specific in-servicing has occurred, ask your manager if a refresher can be scheduled. Becoming a champion for your unit and offering to participate in unit-level reviews of the problem. Your knowledge on the issue is invaluable. Seeking out opportunities to provide input into unit and/or hospital-wide policies and procedures. Such topics may include determining default alarms for the equipment being used, evaluating the need to upgrade to the next generation of monitoring equipment, developing a culture of suspending alarms when nurses perform patient care that produces false alarms, standardizing monitoring practices across clinical environments, being a patient advocate and engaging the entire care team in discussions on whether a particular patient should be monitored, and if so, what parameters should be activated and what limits should be established. To demonstrate how you can make a difference in the area of clinical alarm management during direct patient care, let's look at another case study. Hattie Green is a 65-year-old patient with a history of congestive heart failure, CHF, who was admitted to your unit after a right upper lobe lobectomy. On post-op day 2, the physical therapist working with her is walking her in the hall for the first time since surgery. Before she got up to walk, her cardiac monitor showed sinus rhythm with a heart rate of 88. While she's walking in the hall, you hear a crisis alarm. When you look at the monitor, you note that she is now in atrial fibrillation with a heart rate, HR, of 160. The monitor's HR limits are set at 40 and 150. You and the physical therapist walk her back to her room. Her blood pressure is stable at 124/68. Pulse ox is 97%. Respiration rate is 24. Once she is settled in her bed, her heart rate lowers to between 100 to 116, but she remains in atrial fibrillation. Her provider is at the bedside and states the patient has been in atrial fib in the past. After 30 minutes, her heart rate is between 80 and 100. However, her monitor continues to alarm for an irregular heart rate, atrial fib. Let's take a couple of minutes to think about this scenario. From the actions listed on the next slide, select the best answer choice or choices. Click the letter below that best completes the statement. At this time, what is the best action or actions to take? A. Customize the monitor's alarms by turning off the irregular rhythm and/or atrial fibrillation alarm since the patient is in atrial fib, an obviously irregular rhythm. B. Reactivate the irregular rhythm alarm if Ms. Green goes back into sinus rhythm. C. Continue to assess Ms. Green's tolerance to increased activity and the atrial fib rhythm. Deactivation of the irregular or atrial fib alarm will prevent non-actionable alarms while the patient is in atrial fib. The high rate alarm will capture any episodes of rapid ventricular response rate. Should Ms. Green convert to a normal sinus, you will want to reactivate the irregular heart rate alarm to capture any additional atrial fib episodes. In addition, since atrial fib can impact exercise tolerance and cardiac output, you will want to observe Ms. Green's overall tolerance to the irregular rhythm. Another way to combat clinical alarm hazards is to reduce, when possible, any excess or non-essential noise within the clinical environment. Physiologic monitors are just one of many devices found on clinical units that have an alarm system. Not only should the patient's physiologic monitoring systems be evaluated, but all equipment, for example IV pumps, ventilators, feeding pumps, within the patient care area should be proactively monitored for the potential role they play in producing noise. For example, when rounding on patients, the nurse may quickly assess when and if electrodes are adhered to the skin, and or if lead wires are securely attached and are attached to the appropriate electrode. Eliminating a potential alarm prior to its occurrence reduces environmental noise. There are many negative effects of noise on patients and families, such as sleep disturbance, delirium, increased blood pressure and heart rate, as well as on immune system function, healing, and recovery, which can increase hospital length of stay and impact family and patient satisfaction. In addition, staff can experience increased occupational stress, reduced staff work performance, and failure to recognize and/or respond quickly to medical alarms. The bedside clinician is in a position to immediately begin to impact nuisance alarms, and thus combat environmental noise as a whole. As discussed earlier, AACN, a national leader in the critical care arena, published guidelines on alarm management in 2013. Let's review these guidelines in a little more detail. As identified by the Joint Commission, poor skin prep and electrode placement are two of the most prominent causes of nuisance alarms. Therefore, the AACN strongly urges that steps are taken to reduce skin impedance and enhance conduction of the ECG signal. This includes clipping of excessive hair at the electrode site, followed by proper skin cleansing with soap and water. Daily change of ECG electrodes is now considered standard practice, and more frequent changes are encouraged if necessary. In addition, a recent study by Albert et al., 2015, examined the use of disposable lead wires versus reusable lead wires. The study results showed disposable lead wires reduced no telemetry, leads off, and leads fail cardiac monitor alarms when compared to reusable lead wires. The AACN recommendation that ECG monitor alarm parameters and levels be customized is based on research conducted by Graham and Kvach that showed customization of alarm parameters lowered the rate of critical physiologic monitor alarms by 43%. The Joint Commission has cited the failure of tailoring alarms to specific patients as yet another cause of nuisance alarms. The AACN recommends that customization of alarms occur within 1 hour of the nurse assuming care of the patient and as the patient's condition changes. Equally important is the customization of delay and threshold settings of other physiologic monitoring equipment. In research by Johns Hopkins, pulse oximetry alarms dropped by 63% by reducing the standard low SpO2 alarm limit threshold from 90% to 88%. In addition to the standards of practice emphasized by the AACN, the bedside clinician can do other practical things to improve cardiac monitoring. Before we discuss these proactive tips for reducing non-actionable alarms, let's review the following case study on electrode management. Jerry Waterston is a 47-year-old male admitted to your telemetry unit with a history of obesity, pancreatitis, and diabetes. He came to the emergency department complaining of chest pain and shortness of breath. His EKG showed a 4 mm ST segment elevation in the inferior lead, and his cardiac biomarkers were positive. His blood pressure was 160/90, heart rate 96, respiration rate 22, and temp 99. When you arrived at the room, the tech was placing him on telemetry. Since you were busy, you were grateful for the assistance. Per cardiac monitoring, the patient was in sinus rhythm with rare unifocal PVCs. Over the next few hours, his monitor alarmed several times for cannot analyze and leads off. When you checked Mr. Waterston, he is visiting with family, but acknowledges he gets nervous every time the alarm sounds. Let's take a couple of minutes to think about this scenario. From the actions listed on the next slide, select the best answer choice or choices. Click the letter below that best completes the statement. At this time, what is the best action or actions to take? A. Check whether the patient has medication ordered for management of restlessness. B. Check vital signs. No additional steps are required if vital signs. The patient has an evidence-based indication for monitoring, so you will want to optimize the monitoring. Cannot analyze and leads off alarms are critical alarms, as no monitoring is taking place during these alarm conditions. So, what steps should you take? Check electrode placement on the patient's chest to ensure they are securely attached and not over bony prominences. Evaluate whether the electrode sites were properly prepared. When you go to the bedside, you realize the patient has a very hairy chest and the electrodes are not adhering well to the chest wall. You use clippers to remove the hair, clean the area with soap and water, and abrade the area with a gauze pad. You apply the electrode to the lead wire and place it on the patient's chest. Monitor the occurrence of cannot analyze and leads off to ensure your interventions were successful. Plan to change the electrodes again in 24 hours, or as per the manufacturer's recommendations. To avoid non-actionable alarms, ECG basics for cardiac monitoring should be observed. Let's review some of these basics. Once proper skin prep has occurred, inspect all electrodes prior to use. Electrodes should be stored according to unit guidelines and manufacturer's instructions. Verify the contact gel is intact and moist. When used with snap-on lead wires, attach the lead wire to the electrode before applying it to the patient's chest. Place electrodes over soft tissues or close to bones. Avoid placing over bony prominences, thick muscles, or skin folds. When placing the electrode, secure one side against the skin and then the other. Finally, smooth down the circular edges of the patch to ensure proper skin contact. Follow the AHA guidelines for lead placement. Make sure the correct lead wire is attached to the correct electrode. Secure all connections leading from the electrodes and lead wires all the way to the monitor. Once the monitor is turned on, evaluate the patient's ECG waveform. Ensure the signal is stable, of good quality, and with adequate QRS amplitude. Set the parameters and limits according to your facility's policy and the patient's condition. Encourage your facility to consider single-patient use lead wire systems. A 2015 study found that one brand of single-patient use ECG lead wires were less likely to lose signal and showed a 29% reduction in no telemetry, leads off, or leads fail alarms as compared to standard reusable wires. Additionally, the disposable ECG leads were noted to be associated with reduced rates of hospital-acquired infections. Troubleshoot false or non-actionable alarms. Example issues: gain setting too high, high alarm limit set too low, or low alarm limit set too high. Remember, treat the patient and not the monitor. Before concluding this course, please complete the following scenario and knowledge check as a way to review the information presented in Section 3. Jane Bradley is an 84-year-old female who was admitted to your telemetry unit from the emergency department, ED, with a history of CHF, chronic obstructive pulmonary disease, COPD, diabetes, and a cerebrovascular accident, CVA, with residual left-sided weakness. Mrs. Bradley presented to the ED complaining of shortness of breath and chest pressure. Her EKG was unchanged, and her cardiac biomarkers were negative. Vital signs: blood pressure 138/82, heart rate 82, respiratory rate 22, pulse ox 96%. She is in sinus rhythm with frequent unifocal PVCs. When she arrived on your unit, she was pain-free and denied shortness of breath. Ms. Bradley is on the monitor, and you notice she is currently averaging 12 to 15 PVCs per minute, which has created multiple non-actionable alarms. The alarms are distracting, pulling you away from your other patients. You are considering adjusting the alarm settings. What information do you need prior to contacting the provider? What are your options? What information do you need prior to contacting the provider? Assess the patient to ensure there is no correctable cause for the PVCs, such as an electrolyte imbalance. Review the alarm data history to determine the number of PVCs the patient has been averaging. Verify the current PVC settings. The current PVC alarm default is 10 PVCs per minute, and the patient is continuing to average 12 to 15 PVCs per minute. You did not identify a correctable cause for the PVCs. Review with the provider your assessment and your plan to customize the PVC alarm limit to make the alarm actionable. What key points should you discuss with this patient's provider? Emphasize the need for actionable alarms. Remind the provider that the PVC alarm and the ventricular tachycardia alarm are completely separate, so adjusting one does not influence the other. If the provider plans to treat the PVCs, how many PVCs per minute will trigger an intervention? Set the PVC limit appropriately. If the provider does not plan to treat the PVCs, the PVC count alarm may be turned off. Click the letter below that best completes the statement. Which action is not recommended when prepping the skin for electrode placement? A. Wash the skin with soap and water. B. Abrade the skin. Use of alcohol is not recommended as it tends to dry out the skin. Points to remember. Clinical alarms are designed to notify clinicians of immediate or potential patient harm. Physiologic monitors are the most critical source of alarm hazards. Today, there are many key players in the advancement of alarm safety. National guidelines have been developed by the AHA, AACN, and ACC. Clinical staff play a large role in making substantial changes to clinical practice. Every clinician can help reduce clinical alarm hazards.
Okay, so that's the end of the online course. Next is evaluation. All right, let's do it. Oh, it's just evaluation. So discontinue education activity in the following. Yes, discuss the scope significance of clinical online hazards and their effect on everyday practice. To discontinue education activity, meet the following objectives, explain national initiatives regarding clinical hazards and their integration into the workplace, apply proven clinical strategies to practice in order to reduce clinical awareness standards and improve patient safety. Course activities, the activity and educational needs, the education material is accurate, current, and useful. Teaching and learning methods include active learning. Yes, learning assessment activities were appropriate. The activity content was presented in a fair, unbiased, and balanced manner. Plan to change aspects of our practice as a result of participating in this activity. What changes in your practice or are you committed to making after participating in this activity? How will these changes improve patient safety experience and their outcomes? All definitely have to make sure that I am knowledgeable and updated with every machine and system that facility my work at. Definitely have to make sure and knowledgeable of every machine system that has which can pro which can lead to proper patient care and faster recovery. Please briefly describe a practice problem issue you've encountered in the location. To address this problem issue, practice problem issue. I encountered any significant issue at the moment. Deep evaluation. Oh, and now there's a process. Wow, good luck. 10 questions to pass 80%. 8 out of 10 questions can complete test. The processes. I might not be able to take it. Okay, I can do this. Negative effects of noise on patients include which of the following: lower pulse, sleep deprivation, abdominal cramps, increased healing time. Lower pulse rate and blood pressure. Negative effects of noise on patients include which of the following: lower other than negative effects. Managed to negative effects of noise are What are the negative effects? What is that? Right. I was writing here negative effects of my sleep disturbances. Concentration. Sleep disturbances. Negative effects. Sleep disturbances, yes. And lowered pulse rate. It should be increased. Increased healing time. Increased healing time. Right. Increased healing time. Yes. With our increased hospital length of stay and increased hospital length of stay and bathroom expansion and degree of abdominal cramps. Yep. Which clinical alarm hazard has been shown to contribute to adverse events? Improper alarm setting, which is our patient alarm fatigue, alarm hazards, all of the above. Let me double check. Why is it not showing? What are the alarm hazards? Yes. Alarm hazards. Right here. Which clinical alarm hazards? Well, today. Clinical alarm hazards. It's improper settings are patient unnecessary. Adverse events in the hospital. In hospitals nationwide. Mm. Okay, I will have to stop share because I need to use the bathroom. Okay, an hour 24 minutes approximately, which is true because it says here that it takes an hour 27 minutes. Okay, I really need to use the bathroom now. Okay, thank you. I'll stop recording.